Well, here we are at the top of the hour. Maybe we can begin. I'm Chris Fanta. I'm delighted to welcome you today to Asthma Grand Rounds and to a very worthwhile presentation by Drs. Nancy Lange and Barry Shea on update in pulmonary function test interpretation, the how and the why. Before we begin, I'd like to just look ahead to, since this is the last of this academic year's programs, to look ahead to the schedule for asthma grand rounds for next year. And there are a series of, I think, very exciting talks coming up in the future that we can look forward to. There'll be a presentation on novel imaging techniques and phenotypes in both asthma and COPD. A talk on allergen and damage sensing epithelial cells in the airways, sex differences in asthma, what genomics can teach us. A talk on predicting clinical responses to asthma biologics. And then we'll finish with a pro-con debate on the interesting topic, remission is currently a legitimate target in asthma management. Today, just the administrative stuff. We welcome your questions that we'll put to our speakers at the end of the presentation. Please put your questions into the chat section on the Zoom. For CME credit that'll be awarded after today's session, we need your name and your degree. And if you could send it to Dr. Israel's email address, his assistant, it's Israel, ASST, Israel Assistant at bwh.harvard.edu, and we will submit it to Harvard Medical School for CME credit. And then, really no technical problems today, but if you did have any, just send a quick email to BWH Webcast Troubleshooting, BWH Webcast Troubleshooting at partners.org and get help. So this morning, we're delighted to have two experts in this area, Drs. Nancy Lange and Barry Shea. Dr. Lange-Vaidya is an associate director of the Pulmonary Function Laboratory at the Brigham Women's Hospital with a special clinical interest in asthma. And Dr. Barry Shea is medical director of the Pulmonary Function Laboratory at Mass General Hospital with a special interest in interstitial lung diseases and pulmonary fibrosis. And they're now both part of the Pulmonary and Critical Care Medicine Division, that is the Mass General Brigham. And we're eager to hear from them an update on pulmonary function test interpretation. And I believe Dr. Lange-Vaidya will begin. Thank you, Nancy.
Thank you so much, Chris, for inviting me to speak today with Barry and for the introduction. Let me just get my screen shared. All right, can you see it? Okay, great. All right, good morning, everyone, and welcome to our Asthma Grand Rounds on PFT. These are my disclosures. Today, we're mainly going to focus on these updated guidelines that were published in 2022 and go over some of the major changes from the previous version from 2005. This is an outline of our overall talk today. I'll be talking about the change in how we grade severity of pulmonary function test results and the new definition for bronchodilator response. And then we'll talk about some of the interpretation issues, including defining obstruction and classifying physiology. And finally, we'll talk about changes to the reference population and the transition to race-neutral reference equations. So the purpose of PFTs, we do them obviously commonly in pulmonary and in patients with asthma. It aids in the diagnosis of lung disease, helps to evaluate patients with a complaint of dyspnea. We monitor disease progression, treatment response, and toxicity of various therapies, and also use PFTs to estimate risk, including things like perioperative risk and occupational exposures. So first, let's talk about grading severity. So it's important to remember that the PFTs, although they are objective data, they're really just a tool, and we need to keep in mind the broader clinical context they're in. And anyone who's looked at enough PFTs, especially in the context of clinical patient care, has to remember that even though they're objective data and we like to follow these numbers, there's a bit of fuzziness to the categories that we put these results into. And this is especially going to become apparent when we talk about these changes and how it will affect PFT interpretation. We use the lower limit of normal to define whether a patient has normal lung function or abnormal lung function before we grade the severity. But it's important to remember that the lower limit of normal is not necessarily clinically meaningful, meaning it doesn't really define an absence or presence of lung disease. It just gives us a probability that there's a lower chance, a less than 5% chance, that this result is within the normal range based on whatever reference population that we're using. But it's important to remember that lung function is really a continuum, and it's not this sort of threshold type of result. It's also important to keep in mind when we're thinking about normal and abnormal that changes in lung function, even if they remain within the normal range, can still be pathologic and clinically important. For example, if you have a patient whose FEV1 goes from 95% predicted to 80% predicted, that still may be well within the normal range for that patient, but it could be a clinically significant change. So this is the table how we graded severity based on the 2005 guidelines. There were 5 different levels of severity ranging from mild to very severe, and this was based on the FEV1% predicted. Now this is the new way of grading severity. There are 3 different levels of severity, just mild, moderate, and severe, as well as normal, and we use the FEV1 Z-score rather than the percent predicted. I'm sure all of you are familiar with a Z-score in general. It represents how far from the predicted value based on the reference population your patient's value is in standard deviations. A Z-score was found to be more consistent across age and sex compared to percent predicted, and overall has a better correlation with survival than percent predicted, which is why the change was chosen. It's important to keep in mind this is the grading of the severity of the lung function impairment and not disease severity, which of course will always include things like quality of life, functional impairment, symptoms, etc. And I think this is really important to keep in mind when our patients are reading their own results on a regular basis. I've definitely had patients who read that they had severe obstruction on their PFTs and they were upset because they felt like they've been doing all the right things, exercising, feeling better, etc. So we sometimes need to remind ourselves and our patients that this doesn't tell us everything about how their disease is. This figure just shows the overall correlation in the lightest blue bars with FEV1 Z-score and overall mortality. And I put in the different categories using the red lines of mild, moderate, and severe. And you can see just within the groupings that the levels are relatively similar, which is part of the reason for changing from 5 different categories to 3 different categories of severity. Now, this is sometimes something we need to remind our fellow pulmonologists as well, that it's the FEV1 Z-score and not the ratio Z-score or percent predicted. It's not the TLC or the FVC that we use to grade severity. And this is regardless of the type of impairment, whether it's obstruction, restriction, a mixed obstructive and restrictive picture, or this new non-specific pattern. So I explained how we changed the grading of severity, but how is this going to affect your patients? Well, this figure shows in the different shades of blue, the old way of grading severity, and then the black lines delineate the new way of grading severity. And you can see the change is most significant for people who are older. So these top 2 bars here are an 80-year-old female and male. You can see that very severe goes to severe, but patients who previously had results that were read as severe may now be called moderate. And the moderately severe and moderate are collapsed together into one category and may now be called mild. And people who told they had a mild abnormality previously will now be considered normal. You can see the change is less drastic as patients are younger. This is a 50-year-old male and female, then going down 25-year-old male and female. So the changes will be most drastic in the oldest age group, but patients still may change severity category when they go from the old to the new interpretation system. So this is just an example from our lab of how a patient's results may change in terms of the interpretation without really any change in their, without any change at all in their lung function. So you can see this patient has an FEV1 of 1.78, which is 54% predicted, an FVC of 3.34, which is normal at 88% predicted, and a ratio of 53%, which is low. So this patient has obstruction. Using the old way of grading severity, we would have looked at the percent predicted FEV1, and this would have been called moderately severe obstruction. But using the new way of grading severity, we use the Z-score, and this is now called moderate. So it's not a big change, but just to point out, this patient didn't improve their lung function. They just have a new way of, we have a new way of interpreting it. And if you have the same printouts as our lab, you don't need to memorize the Z-score gradations. You can just use these letters to cheat. So the A means it's abnormal. The N means it's normal. So they have an abnormal FEV1 and an abnormal ratio. And then this large M stands for moderate. If it's a small m, it's mild. If it's an S, it's severe. So it makes it easy to interpret if there's no official interpretation on there yet. Okay, now moving on to the new definition for bronchodilator response. So our old way of defining bronchodilator response was a 12% and a 200 cc change relative to the measured baseline FEV1 or FVC. The new way of defining it is a 10% change relative to the predicted value of FEV1 or FVC. This change was made because it minimizes the effect of height, age, sex, and baseline value in assessing bronchodilator responsiveness. And the threshold was chosen based on studies of healthy subjects showing that 10% was around the upper limit of normal for healthy subjects' bronchodilator response. It supposedly was also chosen because there's a better prediction or separation of subjects with asthma from normal or other lung diseases, but I'll show you some data that calls this into question. And the guidelines do state that an over-reliance on strict cutoffs for bronchodilator responsiveness should be avoided, meaning it's, again, not this perfectly dichotomous trait, but it should be seen on a continuum and always taken into clinical context. So this is the slightly complicated way of calculating this, this response. It's the post-bronchodilator value in liters minus the pre-bronchodilator value in liters times 100 over the predicted value, but I'll show you an easier way of figuring this out. So let's look at a couple of examples using the old and the new criteria and see how this will change interpretations for patients. So this patient, looking at the old criteria, their FEV1 goes from 0.51 to 0.58, which is a 70 cc change, and 14%, which does not meet the old definition for bronchodilator response. On our printouts, again, this percent change is calculated for you in this column here that says percent change. Now, when you look at the FVC, the change was 360 cc's and 21%. That does meet the criteria of at least 12% and 200 cc's. So by the old definition, this patient has a positive bronchodilator response. Now, using the new criteria, again, the FEV1 does not meet the definition for bronchodilator responsiveness. Again, you can do this complicated calculation, which is a change over the predicted value times 100, which equals 3%. If you have one of the more recent printouts, there's also this column that says BDR, and that calculates the change for you. Or the easiest way is just looking at the percent predicted column, seeing it goes from 22 to 25% predicted, and that's a 3% change, which again doesn't meet the 10% threshold. But looking at the FVC, using those same ways of calculating, we can just look at this column. They do meet, they change by 12%. So this patient, both by old and new definition, has a positive bronchodilator response. Now let's look at another example. So using the old definition, this patient does meet the criteria for bronchodilator response with a change in FEV1 from 1.83 to 2.06, which is a 13% and 230 cc change. But using the new criteria, doing that math, or just looking at the change from 59 to 63, from 61 to 69, the patient only changed 8%, so they don't meet criteria. So does this mean now this patient used to have asthma and now they don't have asthma? Of course not. We have to take this into the clinical context, but I just wanted to show you an example of how this may change the interpretation for patients, but you still need to take the whole clinical picture into the context to decide what it means. So there are several different publications just doing the math of looking at the change in prevalence of bronchodilator responsiveness using the old definition and the new definition. And for the most part, depending on the population, the prevalence of bronchodilator responsiveness goes down. So the criteria are a bit more stringent compared to the old definition. But this paper, I think, has a little bit more useful information than just simple math and change in prevalence. So they looked at only patients with obstructive lung disease, around 7,000 patients from 18 different countries who had an MD diagnosis of asthma, asthma and COPD, or COPD alone. And I condensed one of the main figures over here on the right just to make it easier to look at the main information that I wanted to discuss. So you can see on the top, it's asthma, middle is asthma and COPD, and the bottom is COPD. The different shades of each given color was mild, moderate, and severe. And generally on the left side is looking at the prevalence of bronchodilator responsiveness using the old definition, and on the right side using the new definition. So you can see just by eyeballing this from left to right, the overall prevalence is slightly lower using the newer definition, just because the bars on the right side are slightly lower. They also pointed out that there's a similar prevalence using either definition of bronchodilator responsiveness looking among the various diagnoses. So you might think that in asthma, it would be much higher compared to COPD alone without asthma, but you can see, although maybe the bars are slightly higher, it's not enough really to differentiate asthma from COPD. And they looked actually at the sensitivity and specificity of both definitions and found that neither one really was that good at discriminating asthma from other obstructive lung diseases, although the more recent definition has a higher specificity, which could be useful. They also looked at what was associated with positive bronchodilator response in the patients with asthma specifically. And they found that asthma patients with a positive bronchodilator response had generally lower lung function, higher exhaled nitric oxide, worsening respiratory symptoms. They had a higher likelihood of having had a hospitalization for an exacerbation in the prior 12 months. A higher proportion were on triple therapy, maintenance, steroids, or biologics. And they found that the older definition, although not the more recent definition, predicted exacerbations in the following year, which is obviously a useful tool in clinical practice. And what they propose based on these findings is that we don't really use bronchodilator response as a diagnostic criteria for asthma versus COPD, or as a way of really separating out these diseases, but see it more as what they call a treatable trait, and use it as maybe a marker of a patient who needs closer monitoring or stepping up of therapy, or who's more at risk for bad outcomes due to their clinical, the severity of their disease. Okay, lastly, I'll just talk briefly about one aspect of interpretation, then I'll hand it over to Barry. Oops. All right, so I'm just going to talk about the definition of obstruction, and this is really not new in these guidelines, but it is emphasized as something important to keep in mind. So I wanted to just bring it up as it's relevant, of course, in our asthma patients. So the ATS and ERS, the American Thoracic Society and European Respiratory Society, emphasized that we should use the lower limit of normal as a way of defining obstruction. This depends, of course, on the reference population you use and requires some calculation. And it depends especially on age. As you can see in this figure on the right, they have age on the x-axis and the ratio on the y-axis. This is the predicted value of the ratio for males and females in the solid line, and the lower limit of normal in the dashed line. And you can see it just goes down with age, and that's the expected sort of normal aging of our lungs. And the ATS and ERS feel strongly that we should use the lower limit of normal, because using a fixed cutoff like the 70% on this line here would overdiagnose obstruction in older individuals who are really normal, and underdiagnose obstruction in younger individuals who may truly have obstruction. On the other hand, the GOLD guidelines, or the Global Obstructive Lung Disease Guidelines, use 70% as a fixed cutoff in all age groups. And that's due in part to simplicity. There's no calculations involved or reference populations. You don't need to choose a specific reference population. It's used very frequently in trials of treatment, and this is maybe more common in COPD than in asthma. And it may correlate better with clinical outcomes, and I'll show you just a little bit of data on that. So in this study, they aim to answer the question as to whether defining obstruction using the lower limit of normal or the fixed cutoff of 70% was better at predicting obstructive lung-related outcomes, including hospitalization and death. They used data from 4 different population-based studies that had spirometry and COPD-related outcomes, and this included around 24,000 participants with a mean age of 63, and 37% were never smokers. So some of these patients could have been patients with long-standing asthma who have chronic lung changes. They noted the prevalence of obstruction was lower if you use the lower limit of normal than the 70% cutoff, and that's not surprising given that the mean age was 63, so older individuals. Then in this figure on the right, it has the ratio here broken down by 1% increments, and then this is the incidence density rate, or essentially the rate of clinical events, including hospitalization and death from obstructive lung disease. And you can see that generally the rate is inversely proportional to the ratio. As the ratio goes down, the rate of events goes up. And although there's not a clear cutoff or a clear threshold, around the 70% line is around where there's somewhat of an upturn in this rate. I also thought this data was pretty interesting, because usually when I teach PFT interpretation to our fellows or think about it myself, I don't think of the number for the ratio itself as being clinically meaningful. For example, a patient could have a ratio of 50%, and that could mean an FEV1 of 0.5, or it could be an FEV1 of 3, and those patients are very different. But you can see with the lower ratios, regardless of what the FEV1 was, that rate of events is increased. They then looked at the C statistic, which helps to determine how well the given threshold predicts an outcome. So 1 would be a perfect predictor, 0.5 would be no better than chance, and around 0.7 is considered to be a good C statistic. And they found that 0.71 or 71% was actually the best threshold, but it wasn't statistically significant from 70%. And all of the fixed cutoffs were better than using the lower limit of normal in terms of predicting these clinical outcomes. And then, of course, there's always a trade-off between sensitivity and specificity. And so using the fixed cutoff of 70% is a bit more sensitive, especially obviously in the older population. So you may be overcalling obstruction a little bit, but using the lower limit of normal, you may be missing people with clinically important lung disease. So again, the guidelines do recommend using the lower limit of normal to define obstruction, but I thought this data in a pretty large data set of individuals is important for us to keep in mind because it does relate to clinical outcomes. All right, now I'm going to stop sharing and turn it over to Barry for the rest here.
Great, thanks, Nancy. Let me just get my screen share up and get my slides up. And I think that should work. Good, okay, great. Nancy's already talked about sort of the most substantive measurable changes in the 2021 task force guidelines on PFT interpretation, specifically the grading, the severity grading based on Z-score and the new definition of bronchodilator response. But the other important change in the 2021 guidelines compared to 2005 was really more of a philosophical one. It's really where the focus is really on emphasizing using PFTs to classify physiology rather than make a clinical diagnosis. And I think that's a really important change, and this kind of echoes what Nancy was saying earlier about the uncertainty in PFT interpretation. By convention, as Nancy was mentioning, we use the 5th percentile or a Z-score of negative 1.645 as the lower limit of normal. And this is based on values from a healthy reference population that are used to define that normal distribution of lung function. But that does not mean that if a value is less than the lower limit of normal, it is abnormal for that patient, right? By definition, 5% of people, I have to get my little pointer here, 5% of people will have a value below the lower limit of normal, despite having no evidence of lung disease. So there's a 5% chance that these patients, below this cutoff will have a false positive test. And the 5th percentile does not really need to be the lower limit of normal. It depends on where this cutoff is used. If you have a patient whose value is in the 1 percentile, there's a 99% chance that's abnormal, still a 1% chance that that's abnormal. Conversely, you have a patient whose value is in the 10th percentile, that'll be in the normal range. That would be considered normal, but there's still a 90% chance that that's abnormal for that patient. I mean, I think one way to think about this is think about serum creatinine, right? We see this all the time in the hospital where someone's creatinine goes from 0.4 to 0.8. It's still normal, but we know that it's doubled, and we know that that means there's abnormal kidney function. In the same way, if someone's PFTs drop from from 70% from the 70th percentile down to the 40th percentile, that's within the normal range, but that's a change for that patient. The ideal scenario would be comparing a patient's PFTs during disease to what they were during health, but most of the time we don't have PFTs from when those patients before they develop lung disease. So it's I think it's why we really shouldn't be using PFTs to define the presence or absence of lung disease, because there's considerable uncertainty as to what's normal versus abnormal. And I think one of the points of emphasis is that this degree of uncertainty is greatest near the lower limits of normal, right? So we have this idea that we have a healthy population with a normal distribution of lung function, and then we have a diseased population. There is going to be some overlap in lung function measures in these two groups. So I think this is really an important concept that we have to think about when looking at all of the different PFT numbers that we see. So in terms of defining normal and abnormal, this really wasn't any different with the 2021 guidelines versus the 2005 guidelines. As Nancy was mentioning, still recommending use of the lower limit of normal or the 5th percentile. Still recommending using that for all grades, FEV1, FVC, TLC, DLCO, not using fixed cutoffs like 80% predicted, and not using fixed cutoffs like a ratio of 0.7. And the reason for this is that the lower limit of normal as a percent predicted declines with age. So these are data from the GLI 2012 initiative, looking at FEV1 and FVC, males on the left, females on the right. And this is graphing FEV1 FVC as the lower limit of normal as a percent predicted, right? And see that throughout adolescence and young adulthood, the lower limit of normal is around 80% predicted. But as people age, that lower limit of normal drops down to 75, 70, even below percent predicted. Again, recognize that there's uncertainty as to what's truly normal. In terms of classifying physiological impairments, really that was also not different in the 2021 guidelines versus the 2005 guidelines. They did propose several new kind of algorithms for PFT interpretation, and I'm going to show them to you here just kind of briefly. There was an algorithm for interpreting spirometry, starting with whether the ratio is normal or abnormal, and you can kind of go through these different algorithms. There was a much more complicated one for lung volumes, which, again, starting with the TLC and following a variety of different paths, and another one for diffusion capacity. I'll be honest, and Nancy and I have talked about this, I find these different algorithms really confusing, and I think they're kind of hard to follow. And I think that at the core, the way we define different deficits based on PFTs is still essentially the same, right? We define obstructive deficits based on an FEV1 FVC ratio less than the lower limit of normal, restriction based on the low TLC, combined deficits based on a low ratio and a low TLC, and gas exchange impairments based on a low diffusion capacity, importantly corrected for hemoglobin. As we've been emphasizing, we really have to pay close attention to values that are near the lower limit of normal and in that zone of uncertainty. We always have to compare to prior tests when they're available. Look for a bronchodilator response, unmasking obstruction, because again, values that are within the normal range may be abnormal for that individual. So they're just a couple of examples. So this is some PFTs from our lab, just spirometry. You can see these spirometry are normal. The FEV1 is normal, 97% predicted. The FVC is normal, 110% predicted. The FEV1 FVC ratio in this case is 0.67, which is above the lower limit of normal, 0.65 for this population. So these would be normal spirometry. But after inhaled bronchodilator, we see a small increase in FEV1 and a larger increase in the FVC that would have met either the 2005 or the 2021 bronchodilator response guidelines. So we know, based on this bronchodilator response, that these baseline spirometry were abnormal for this patient. So we know that this patient has airflow obstruction based on the presence of the bronchodilator response. Similarly, these are spirometry from another patient, again, normal FEV1, normal FVC, a normal ratio, but low normal, it's 0.65. The lower limit of normal here is 0.62. When we look at the trend over time, we can clearly see that the FEV1 has gone down, as has the FEV1 FVC. So the FEV1 has gone down by over 650 milliliters. The FEV1 FVC ratio has gone down from 0.74 down to 0.65. So again, even though these spirometry values are normal or within the normal range, we know that they're abnormal for this patient based on the comparison to prior. Again, much like that serum creatinine that went from 0.4 to 0.8, being abnormal for that patient. Another sort of deficit that was emphasized a little bit more in the 2021 guidelines was what they're referring to as the non-specific pattern. So these are patients who have a low FEV1 and or FVC, have a preserved FEV1 and FVC ratio and a preserved TLC. And the question is what kind of physiologic abnormality do these patients have? In some cases, this is early restriction, right? The TLC may be normal, but it may be abnormal for that patient, and we may be seeing early restriction. This may be obstruction with gas trapping, and sometimes you can see clues for that in other parts of the testing. Is there a bronchodilator response, unmasking obstruction that was not seen with the baseline spirometry? Is the slow vital capacity significantly larger than the forced vital capacity? We can see that obstructive lung disease because of the dynamic airflow obstruction that occurs with a forced vital capacity maneuver. They took out actually in the 2021 guidelines looking at the FEV1 slow VC ratio as a way to kind of be a tiebreaker to look for obstruction, largely because we don't really have population data for FEV1 slow VC ratio. But I think that seeing that a big difference between the slow vital capacity and forced vital capacity can be a clue that there may be some airflow obstruction with gas trapping. In many cases, this may be just reduced effort. Either the patient's not exhaling all the way to RV, either there's glottis closure, or there's lack of a plateau on the volume time curve, or they fail to inhale to TLC. And sometimes we can get a clue to that because the forced inspiratory vital capacity or the inspiratory volume on a DLCO may be significantly higher than the forced vital capacity. But that's really going to be based on our assessment of the quality of the test data. And it turns out that if you follow these patients over several years, about a third of them go on to develop kind of a frank obstructive or restrictive deficit, whereas the other 2/3 remain somewhat nonspecific. The other kind of term I want to at least just acknowledge is this term referred to as PRISM, or preserved ratio impaired spirometry. And I bring this up because it was brought up in the guidelines and you see it in the literature. But I think the thing to emphasize about this PRISM pattern is this is really an epidemiologically defined abnormality. So these are based largely on population studies where they've done spirometry, and they defined it based on low FEV1 and or FVC with a preserved ratio in situations where lung volumes were not measured, right? In a lot of these population studies, they do spirometry because it's much harder to do, much more, more involved equipment to do lung volume measurements. So it's patients with low FEV1 and or FVC with preserved ratio. In these population studies, the prevalence is somewhere around 10%. It varies from study to study. But importantly, this is based on fixed cutoffs. We're not using lower limit of normal. These studies usually used a ratio of FEV1 FVC of 0.7 and used 80% predicted as their cutoffs for FEV1 and FVC. In most cases, when you do follow up and you're able to do more comprehensive pulmonary function testing, most of these patients are turned out to have either obstruction or restriction. So I think you'll see this a lot in the literature. I think it's important just to recognize this is not necessarily a physiologically defined or a different set of lung physiologic anomalies. So the last thing, and probably what I'll spend most time on, is talking about reference equations, because it's hard to talk about PFTs without acknowledging the importance of the reference equations. And I think that's something that we for years didn't really pay a lot of attention to. So we need reference equations because there are a lot of different factors that influence lung function, right? Reference equations are intended to provide predicted values of lung function against which a patient's lung function can be compared. And there are many factors that influence lung function. We know that age is a big factor. The lungs grow during childhood and adolescence. And then after sort of the age of 30 or so, there's a decline in lung function over time. Standing height is also a big determinant of lung function. And standing height we think of sort of as a proxy for chest size or torso length. Biological sex is also a value. Even when you account for age and height, there are differences in lung function based on biological sex. The 2021 guidelines kind of reiterated that they recommend the use of biological sex and not gender identity in the predictive equations. And largely because we really don't know how gender affirming hormonal therapy and the timing of it can affect lung growth. There is certainly a good chance that hormonal therapy could affect lung growth, and it certainly should be considered. But I think as of right now, we just don't know enough as to how that could affect our predicted values. And then we also know that lung function varies based on race and ethnicity. And this has become somewhat controversial over the years, but I think we'll talk a lot about that today because the recommendations have changed. And so there are innumerable, maybe hundreds of different predicted equations that have been developed. The Global Lung Initiative, or GLI, is probably the single largest collection of lung function measurements from across the lifespan from healthy populations around the world. And for the purposes of predicted equations, healthy is generally defined as lifetime non-smokers with no respiratory symptoms and no known history of chronic lung disease. The most comprehensive data in the GLI database are for spirometry, but even that is still not representative of all different populations around. Importantly, GLI also has equations for diffusion capacity and for lung volumes, but those are predominantly derived from Caucasian populations, those of European ancestry. And so when the GLI group kind of did this analysis of spirometry from populations, whatever populations they could collect around the world, they found that the lung function in terms of spirometry, again, this is FEV1 on top and FVC on the bottom. This is males on the left. This is females on the right. They found that all the different populations measured could kind of be grouped into 4 different categories. They had a Caucasian group, a Northeast Asian group, that's the kind of a heavy dotted line here. There's a Southeast Asian group, which is the fine dotted line, and then the African American group, which was the lowest line down here. And they could see that all the different populations could fit into one of these 4 different groups. And so at the time of the 2021 guidelines on PFT interpretation, they recommended use of the GLI equations for spirometry, which are these 4 different groups, recognizing that these do not capture all of the world's populations. And there is this multi-ethnic or GLI other equation, which was an average of these 4 equations for people that either didn't fit into those different populations or perhaps were multiracial, multi-ethnic. And you can see, if this is again from the GLI 2012, if you look at FEV1 and FVC, females on the left, males on the right, compared to the Caucasian population, this is the percent difference compared to the Caucasian population. If someone is Black or African American or Southeast Asian, the predicted lung function measurements were anywhere between 10 to 15% lower for those populations versus the Caucasian population. The Northeast Asian population was a little bit lower, but pretty similar to the Caucasian population. And there was acknowledgement at the time of these guidelines, the 2021 guidelines, that the differences in these different population groupings that were observed in the GLI initiative may represent sort of intrinsic or genetic differences, but they may be driven by social or environmental determinants of health, and therefore may be a manifestation of health disparities. And so they really acknowledge that we don't know the specific contributions of genetic ancestry or social and environmental factors that contribute to the different levels of lung function that were observed in these different populations. So, in both the 2005 and 2021 guidelines recommended use of these race-specific predictive equations. Both of these guidelines did recommend these race-specific equations over racial correction factors. The thought was that would sort of reduce bias. But again, using these race predictive equations still kind of emphasize the biological differences between different populations and de-emphasize the potential social and environmental factors that could be contributing to lung health, which are admittedly very difficult to measure. And they still have the effect, even using these race-specific equations, still has the effect of normalizing lower lung function in some populations that may not be appropriate. There's other problems, right? It relies on self-identity of race or ethnicity, or sometimes the technician assessment of someone's race and ethnicity based on their skin color, based on their last name. And we know that racial categories are not biological. These are social and political constructs. This doesn't really address individuals that weren't included in the populations that were measured or that fit into those different populations. Doesn't really address individuals of multicultural or multiracial backgrounds. And then, importantly, over the last decade or so, there's really been this growing concern about the inappropriate use of race as a biological variable in medicine. And historically, we know that these observed differences in lung function, the vital capacity, were used as a justification for slavery. And there's really been, I think, a lot of understanding of the fact that certain social and environmental factors can, in fact, influence lung function in adulthood. And so this is from a review article in Frontiers of Pediatrics published several years ago, looking at and this is just a schematic looking at the sort of normal lung development and aging, and what can happen with a variety of different in utero or early life exposures that can alter these trajectories of lung function. And many of these exposures, maternal smoking, secondhand smoke exposure, poor air quality, undernutrition, obesity, respiratory tract infections, are more prevalent in racial and ethnic minorities and those of low socioeconomic status. So we know that there are a lot of social and environmental factors that could be contributing to lower lung function in adulthood, and using race-specific equations can normalize what is likely to be abnormal lung function. And so how do we figure this out? What factors actually do contribute to these racial and ethnic differences in lung function? There have been several studies over the years trying to address these questions, and it's a really hard thing to measure. This is from a systematic review of articles looking at race, socioeconomic status, and lung function in adulthood. And they also looked at body proportions, right? So they found 11 studies that kind of address these different factors. These were all between like the 90s and late 2010s. Most of these were community studies, some were school-based or work-based studies. And they found, in the 11 different studies, there was a wide variation. Anywhere between 3 and about 30% of the difference in lung function between different racial or ethnic categories could be explained by body proportions, right? They did this by looking at sitting height versus standing height. And then anywhere between 2 and 40% seem to be explained by socioeconomic factors. This is another study that was published a few years ago. This was a systematic review and meta-analysis of publications looking at the impact of socioeconomic status on lung function in childhood and young adulthood. And they found 33 studies through the systematic review that met criteria. And this is a combination of cross-sectional and longitudinal studies, most from the US and the UK. And they found that the majority of the studies found a positive association between socioeconomic status and lung function. Here we're looking at the mean difference in FEV1, and you can see on the left, this is lower FEV1 in people from disadvantaged backgrounds versus advantaged socioeconomic groups. So socioeconomic status clearly seems to have an effect on lung function in childhood and early adulthood. Well, what about outcomes, right? So I think that ultimately, and as Nancy was pointing out with looking at bronchodilator response and definition of obstruction, PFTs can be helpful for trying to determine if someone's at higher risk for a poor outcome. And this was a very nice study done by Aaron Baugh and colleagues from UCSF, published just a couple of years ago. They examined how race could influence the association of lung function to COPD outcomes in the spiromics cohort. So they looked at over 2,500 former smokers. That was the spiromics, either former or current smokers in the spiromics cohort. They were either self-identified as African-American or non-Hispanic white. And they looked at the association between percent predicted FEV1, percent predicted FVC, and outcomes. In this case, on the left was St. George's Respiratory Questionnaire. On the right is the COPD assessment tool. And they looked at it based on the percent predicted using either the race-specific equations, which is shown here. And you can see that if there is a correlation in the African-American population in pink, the non-Hispanic white population in blue, there were correlations between percent predicted FEV1 and these symptom or outcome assessment tools, but that the correlations were different in the two populations when these race-specific equations were used. However, when they used race-neutral equations, this is the GLI other equation, the correlations existed, but they were almost identical among the two groups. Again, suggesting that the race-predicted equations were better. The race-neutral equations were better than the race-specific equations for predicting outcomes when looking at percent predicted FEV1 or FVC, and they had several other outcome measures that showed similar findings. This is a study, another study from McCormick and colleagues from Hopkins, looking at the ability of lung function to predict mortality. So this was from the NHANES 3 survey. This is sort of a population survey that was done in the late 80s to the mid 90s. They looked at mortality through 2015. And it's well known that if you take a population, lower lung function is a good predictor of mortality. And what they looked at lung function in white and black individuals, and you can see that when using race-specific predicted equations, there were correlations between lung function and survival. The better your lung function, the better survival. But the ability of FEV1 percent predicted to predict survival was different in the white and black populations, whereas when they used these race neutral or GLI other equations, the ability of lung function to predict survival was essentially identical in the two populations. So again, more data showing that using race neutral equations can be better for predicting outcomes in a variety of populations. So in 2023, the ATS came out with this statement on the use of race and ethnicity in pulmonary function test interpretation. This was subsequently endorsed by the ERS, and their key recommendations were that PFT labs should adopt a race-neutral approach to PFT interpretation and reporting, and they recommend the use of the GLI average equation, or the GLI global, as the recommended race-specific reference equation. And GLI global differs from GLI other a little bit in that the GLI global equation is still an average of the four populations, but it's weighted for the different proportions of the four groups that were included in the data set, versus the GLI other, which is just a strict average of the coefficients from the four different groups. And again, they kind of emphasize the thing that we just talked about, that the reason for this is that superficial appearance shouldn't really be used to infer biologic characteristics. We know that racial categories are not biological, and we know that there's significant heterogeneity within those different racial categories. And the use of race-specific equations normalizes lung function impairment due to modifiable risk factors that could be related to structural racism, in utero, early life exposures, and other socio-environmental factors. And then lastly, as we just showed in the last couple slides, there's sort of a growing body of evidence that race-neutral equations demonstrate equal or better correlation with meaningful clinical outcomes compared to race-specific equations. So what are the practical implications? Well, to some extent, as Nancy was pointing out with the bronchodilator response, like this is math, right? So if you, these are the differences that I showed before in terms of the average FEV1 and FVC in females and males compared to the Caucasian population. So if one is Black or African American or Southeast Asian, switching from race specific to the GLI global equations is going to result in an increase in the percent predicted FEV1 and FVC. If one is white or Caucasian, whether they be Hispanic or non-Hispanic, or Northeast Asian, there's going to be a decrease in the percent predicted FEV1 and FVC. Importantly, there's no real effect on the FEV1-FVC ratio. The FEV1-FVC ratio did not really differ across the different populations that were measured in GLI global. And importantly, the lung volume and DLCO predicted equations are still derived predominantly from Caucasian populations. So there actually may be discordant results, and we see this in PFT sometimes, when a slow vital capacity and a forced vital capacity have very discordant results in terms of their percent predicted. And be very careful when interpreting trends over time. Someone's percent predicted may change because the predicted equations change, but the absolute value may be the same. This has become an issue, certainly in the interstitial lung disease field, where we're looking at progressive pulmonary fibrosis that's defined as an absolute change in the percent predicted. Well, what do you do if the predicted equation has changed? I think it really emphasizes the importance of either just looking at the change in the absolute value or going back and recalculating the percent predicted based on the updated equations. I'd say for most pulmonologists, and I would be interested to hear Nancy's thoughts on this as well, I think most of us would feel this should have minimal effect on our routine pulmonary practice. And I think that for most people in the pulmonary field, I think we understand that we're using PFTs to classify physiology rather than diagnose disease. We all know patients who have a lung function that's within the normal range, but they have lung disease. We all have patients whose lung function is technically abnormal, but they have no evidence of lung disease. And I think we really have to understand that there's uncertainty in PFT interpretation, particularly near the lower limit of normal. And so I think that's always been the case, and that continues to be the case. But there are some real world implications for certain scenarios. For example, if a patient is Black or Southeast Asian, and we could argue the opposite here is going to be the case for white or Northeast Asian populations, but if they're Black or Southeast Asian, they may more likely be evaluated for lung disease based on spirometry showing percent predicted numbers that are now below the lower limit of normal. They may be referred earlier for lung transplant evaluation or listing. They may have increased eligibility for non-invasive ventilation, for lung volume reduction surgery, for disability based on lower lung function values as a percent predicted. There are some potential concerns. Well, we say that more likely to be evaluated for lung disease. Well, is more testing necessarily good? There may be unnecessary testing that's done as a consequence of someone having now lower lung function as a percent predicted. We think that early referral for transplants and more transplants is better, but does that necessarily result in better outcomes? We don't really know. And there may be decreased eligibility for things like lung cancer resection because the lung function now may be lower, life insurance, or even employment opportunities. People have mentioned firefighters where a certain level of lung function is needed for to be employed as a firefighter. So there are some benefits, there are some potential downsides as well. And again, you could sort of switch these sides if you're looking at different populations. And so this is a nice study, I think, that kind of highlights some of the one of the potential downsides of these implications of these changes to GLI Global. This is a study published in JAMA Surgery in 2023. In this case, they recruited over 200 thoracic surgeons to do a survey, and they gave all these surgeons this case vignette. The case vignette was a 71-year-old African-American woman with a 3.6 centimeter lung mass. She was 177 years tall. FEV1 was 1.2 liters, and she was being evaluated for right upper lobe lobectomy. And the surgeons were being asked, how are you going to manage this patient who has this lung mass that's likely cancer? But the group of surgeons were randomized into 3 different groups, and they were randomized to 3 different groups to receive the lung function data as a percent predicted based on either the race-specific African-American equations from GLI, the GLI other equations, or the race-neutral equations. And you can see based on the predicted equations, the FEV1 as a percent predicted was 49%, 45%, or 42% in the race neutral equations. DLCO was the same across all versions. And then they asked the surgeons, well, how are you going to manage this? And in those surgeons that were given the PFT values with race neutral equations had a lower likelihood of recommending a lobectomy versus those who received the lung function values given with the race specific GLI African American group, and more likely to recommend a wedge resection. So now that may not necessarily be better or worse, right? This didn't really look at outcomes. This is a theoretical example, but you can see how there are impacts of these changes to the predicted equations. So we'll stop there. The hour is kind of getting short. And just to summarize, there were some material changes in the interpretation guidelines in 2021 and more recently in 2023. Importantly, it is now recommended that we move away from fixed cutoffs for grading severity, and instead looking at Z-scores to grade severity of obstructive, restrictive, and combined deficits. There's a new recommendation for assessing bronchodilator response that looks at the sort of absolute change in the percent predicted as opposed to the relative change. And really this focus on PFT interpretation, really focusing on the physiology and characterizing physiologic deficits rather than making clinical diagnoses. Understanding that it's very hard to define. And then more recently, a recommendation to switch to race neutral equations. Understanding that there are differences in different populations. These are complex, it's poorly understood why there are these differences, but keep in mind that removing race as a biological variable does have some practical implications. And I will stop there. And I will stop sharing my screen.
Terrific. Thank you both. It was both the how to do and the why we're doing it and the complexities of these new changes. It's very insightful and very helpful. We're close to the hour. Maybe I can just ask you quickly, are you still teaching looking at the shape and contours of the flow volume curve in interpretation, or are we strictly looking at the numbers? For interpretation of
Yeah, I mean, the recommendations really are not to look at the shape of the curve necessarily, and not to, I left this out, not to look at FEF 2575, right? These sort of flows in mid-exhalation. Those can sometimes be a sign of small airways disease, but things like the normal range for FEF 2575 is not that well defined, and it's not that reproducible. So they actually recommend not using the FEF 2575 or mid flows to identify airflow obstruction, and really kind of sticking with the FEV1 FVC ratio.
And I suppose we should highlight the important role of the pulmonary function technician performing the testing. should we, especially it always occurs to me when you're using the change in vital capacity, which relates to how long the patient performed a forced exhalation, to judge a bronchodilator response. But in general, good testing depends on a good tester. Is that fair?
Yeah, definitely. We really rely on our technicians in the PFT lab, our MAs in the clinic, and whoever's performing the spirometry to coach our patients and to tell us that, the software can tell us certain things about whether things were done correctly or not, but we really need the technician's knowledge as well to know that it was a good test, because if it looks like a good test when you're not next to the patient, you may completely, misjudge their lung function when it was really an insufficient effort or something like that. So definitely our respiratory technician's expertise is important.
And I'll add that we were really focusing on PFT interpretation today, but the ATS ERS task force also has guidelines on the technical performance of spirometry, lung volumes, TLCO walk tests. Those all came out initially in 2005, and then they were all updated really like in the last 5 to 10 years. And so they do have a lot of technical standards. And I think it's really important that PFT labs are performing the tests up to those technical standards. And I think that's something we really try to reinforce is the importance of performing the test, because it's another variable that you have to add in, outside of all these biological variables and social and environmental variables, is the actual performance of the test.
Well, thank you so much. Really a terrific presentation. I have lots more questions. I'll email you. But
Thank you, Chris.
Thank you so much, Chris.
thank you very
Thanks, Nancy.
much.
Okay,
You
bye.
Thanks all for joining.